I've always said that hormones they're very dramatic. They're like a diva, divas, and they're the first to react and the last to get better, to fix themselves. And so people often are chasing their hormones and their hormone symptoms. And they're like, I just feel like I'm hurting cats all the time. I'm like, I know. We are so focused on just the uterus or the ovaries as if that's the only thing that defines these hormones, completely forgetting that we have receptors from the top of your head to the tips of your toes everywhere.
And a lot of times we relate symptoms of menopause to hot flashes, but hot flashes are often a really late onset symptom.
Your body is completely changing. It's like going through puberty in reverse. So let's really dial in on the foundations while I'm waiting to get some answers. Like, let's work on what you're eating. Let's work on your type of exercise if you are. Let's focus on sleep. Are you taking care of yourself? Do you feel the weight of the world on your shoulders? Like, what's going on? Because it's only going to get harder if we don't address these foundations as you move through the entire menopausal journey.
Welcome to the Vibrant Wellness Podcast. I'm your host, Dr. Brooke Stubbs, and I'm sitting down with the queen of hormones herself, Dr. Carrie Jones. She is a renowned expert in hormone health, a speaker, consultant, author, and educator with over 20 years of practice experience. She holds a Master's of Public Health degree, was one of the first to be certified through the American Board of Naturopathic Endocrinology, and is a Menopause Society certified practitioner. She formerly hosted the highly popular Root Cause Medicine podcast and now hosts her own podcast called Hello Hormones. Dr. Jones, that is quite an impressive resume. Thank you so much for being here. I'm so excited to dive in all things hormones. As you probably know, being somebody who was in traditional Western medicine culture and was brought up through medical school and traditional residency, I've only recently really dived into the passion of hormone health because a lot of what we learned was to stay away from hormone replacement therapy. So I know surface level, and I know there's so much more to know. So let's dive right in.
Amazing. Well, thanks for having me, first of all. And hormones is my favorite topic to talk about, so I'm ready.
So first, let me say, I love in your bio on Instagram. Oh, and it's also on your website. Hormones is like herding cats. So tell me more, because it's so true. Explain to the listeners what that means.
I've always said that hormones they're very dramatic. They're like a diva, divas, and they're the first to react and the last to get better, to fix themselves. And so people often are chasing their hormones and their hormone symptoms. And they're like, I just feel like I'm herding cats all the time. I'm like, I know. And you have over 50 hormones. And so when you're trying to, get all your cats or your ducks in a row, it can feel overwhelming, but it doesn't have to be.
Yeah. So if you could simplify for us, what does it look like in perimenopause? Because somebody will explain it as a roller coaster, and tell me what's going on.
So I use the roller coaster analogy. When you are cycling, you are on a set roller coaster, or at least you should be. So you go in the first part of your cycle, you go up, you go down, then you have the loop-de-loo, that's ovulation. Then you go up, down again, and then you repeat it, assuming you're not pregnant. So it's a very set roller coaster. Once you get into perimenopause, you kind of go off the tracks a little bit. Suddenly you feel like you're on a whole new roller coaster, but you might go back to the original roller coaster, and then your roller coaster is this massive loop-de-loo. Sometimes there's two loop-de-loos. It just feels wild. And so people go, I don't understand. I signed up for this other roller coaster. Month after month after month, I knew what to expect. And now I'm perimenopausal and I have no idea what to expect. And the hormones are all over the place. Help me.
Yeah. Yeah. And so when that happens, you talk about all of these hormones that are related, and you have these rapid fluctuations in what we're calling your sex hormones like estrogen and progesterone. Obviously, progesterone drops first, but then what happens to all the other hormones? They're very interconnected, right?
Hugely interconnected. They are best friends for sure. So what happens, as you said, progesterone drops first because women don't ovulate like they used to, or the signal to make progesterone, if they do ovulate, isn't as strong as it used to be. So that tends to go down first. And then what can happen is that estradiol, which is the main estrogen, kind of goes on this wild ride. So you can get what's called a loop, a luteal out of phase, which is just a fancy word for you kind of get this double spike of things happening in your cycle, and estrogen is like spike, and you weren't expecting that.
Okay.
So you go from high estrogen symptoms to low estrogen symptoms. Sometimes the signal for estrogen's not there, so all of a sudden it drops down. So you're kind of back and forth with estrogen. Then we have testosterone, and testosterone for some women can just plummet right from the get-go. And others, it's a slow decline.
Okay.
Every woman is different. And all the other hormones are watching and they're taking note and reacting accordingly. So your thyroid hormone, your insulin, your prolactin, oxytocin, your brain hormones like GABA and serotonin, they're all responding just as much to these main sex steroid hormones going all over the place.
And one of the most insightful things I learned in this process is that there are receptors for estrogen in nearly every cell of your body.
Nearly every cell of the body. We are so focused on just the uterus or the ovaries as if that's the only thing that defines these hormones, completely forgetting that we have receptors from the top of your head to the tips of your toes everywhere.
Right. So then that's what leads to the symptoms. And a lot of times we relate symptoms of menopause to hot flashes, but hot flashes are often really late onset symptom.
Yeah, absolutely. That's not usually what women report to me and probably to you either, right?
No.
At the start. Usually it's, I can't sleep. I feel moody. My cycles are starting to change. Like I'm noticing these other subtle or maybe not so subtle symptoms. But when you ask initially hot flashes or night sweats, they're like, no, not yet.
Not yet, but it's like the very vague brain fog or I can't really grab my memory or losing their words or like just fatigue and that abdominal weight gain.
Yes, most definitely, which is important to know because historically, hot flashes and night sweats sort of define the symptoms of perimenopause. So your healthcare practitioner might say, are you having hot flashes and night sweats? And they're like, no. And they'll go, okay, well, you're not perimenopausal. Meanwhile, they're having 4,200 other symptoms absolutely related.
Right. So what should women look for?
Everything we just said.
Okay, right. Yeah. All of the things.
Right, all
anxiety,
the things.
irritability,
Oh my
mood
gosh.
changes, all those things.
Skin changes, hair changes, vaginal changes, joint changes, meaning like joint pain, muscle pains. Now, obviously not everything is perimenopause, but a lot of these symptoms are related to the changes in progesterone, estradiol, testosterone, or can be layered into other things causing all these symptoms.
Okay. And so when they come for these, do you have a compilation of symptoms that lead you down that perimenopause track and you really start with hormone replacement therapy? Or do you want to get some lab values first at a baseline before you start treatment? How do you approach that?
Thankfully, when we're looking at quote unquote, let's say, I don't want to use the word diagnosing because it's not a disease, but like, let's say we're going to give somebody a crown and say, congratulations, you're perimenopausal. We take age and we take symptoms into effect. There's no test to say, yes, you're perimenopausal. So age and symptoms, when somebody's like, I'm 45 years old as an example, I'm having all these things. I'm like, gosh, it really sounds perimenopausal. However, I definitely want to get some lab work on you. Not only to check your hormones, estrogen, progesterone, testosterone, et cetera, but I want to make sure other things aren't being impacted at the same time or I'm not missing anything. Do you have a thyroid issue? Are you vitamin D deficient? Are you iron deficient? Are you B12 deficient? Do you have a glucose issue? What are your lipids like cholesterol doing, et cetera, et cetera? And I think it's important to lab test at the same time you're then instilling the foundations because it can take some time sometimes to get those lab work back. So now I'm like, okay, your body is completely changing. It's like going through puberty in reverse. So let's really dial in on the foundations while I'm waiting to get some answers. Like, let's work on what you're eating. Let's work on your type of exercise if you are. Let's focus on sleep. Let's help your community, your mood, your feelings of joy, right? Like, are you taking care of yourself? Do you feel the weight of the world on your shoulders? Like, what's going on? Because it's only going to get harder if we don't address these foundations as you move through the entire menopausal journey.
Okay. And right now, I feel like there's a big wave right now of hormone replacement therapy being talked about on social media. You know, we're transitioning from what the WHI recommendations were, and we're kind of backtracking that, which I really want to talk about.
Yeah.
And practitioners are now waking up to, okay, this wasn't something I was taught in medical school or in my training. I really want to be on the forefront of this. I know how it can help my patients. I just don't know what lab tests to order. What does that look like? And what is it, the surface level things? Because sometimes we don't really see those as abnormal, but we are really convicted that our patients may need some help.
Right. Right. So I generally do start with some of the surface level blood work,
Okay.
especially in somebody who hasn't been to a doctor or gotten a lab test in a long time. Or maybe and I'm sure you've seen this, they've gone to their provider and said, test me for everything. And it's a few things. It's a metabolic panel and red and white blood cells. Like you just get a few things back and that's
Right.
their version of everything. So I ask for, hey, if you still get a cycle, if you're still bleeding, let's try to get your hormones done 5 to 7 days after you ovulate, if we still think you ovulate. So there's some caveats in here. And I know some like math, we have to figure out, what's your cycle doing. But if we can check your hormones 5 to 7 days, even in blood, if you've never had it done. So estradiol, progesterone, total and free testosterone, plus the other things I mentioned. Let's check your thyroid, your nutrients, vitamin D, B12, et cetera, glucose, insulin, and see where we're at. If somebody said, I've done that, or I'm pretty on top of it, I'd like to go deeper, that's when I definitely go deeper. So that's when I'm looking at like metabolite testing through urine testing, because I want to know where your hormones are going. I want to know where your cortisol is doing. How is your stress? Why aren't you sleeping? Could it be related to your cortisol? Is your energy low because of your cortisol? And so by adding in extra, what we call more functional tests, can give us a lot more information. So but I understand not everybody is ready to start with that right out the gate.
Off the bat.
Yeah. So we start with just regular blood work to start.
Okay.
And then advance from there.
Okay. So I want to hone in on testosterone because you mentioned free testosterone versus total testosterone. Why is it so important to look at both of those dynamics?
So total testosterone is all the testosterone you have. And then hormones are like children. They can't be unattended at any time. So your testosterone is bound to a bus. It's like sitting in a seat with its seatbelt on and it's being driven through your bloodstream. Only a very small percent is allowed off the bus so it can bind to receptors and do the things. That's the free version. So I want to know what's your total. So that's the combination of all the testosterone on the buses. You have 2 main buses and then the little bit that's free. And then I want to know, okay, of all the buses, all the availability, how much is actually free? Because if I have a woman that her total testosterone's really quite low and her free testosterone's low, I'm like, oh my gosh, you don't make it at all. Like it's nowhere. But if somebody has really good levels of total testosterone, but their free is low, I'm like, oh, you just have a lot of buses that's been sitting in seatbelts, but it can't get the seatbelt off and can't float around and do the thing. So it helps me understand more to the testosterone picture.
Okay. And when we look at women's reproductive hormone balance, explain to us the levels of testosterone in our body versus estrogen, because there was a time, I think people are opening up to it more, but there was a time where women would be really scared about testosterone and getting on supplementation.
And women have a lot more testosterone than they think.
Right.
Like a lot more, right? And so we actually have more molecules of testosterone in our body than we have estradiol, the main estrogen. But it's like a ratio or a balance between the two. So we are more defined by our estrogen. We have more estrogen receptors. Estrogen really is what sort of does the thing and helps make us who we are. But we can't neglect testosterone. Testosterone plays a role in mood, motivation, muscle gain, libido, right? It does bone health. Like testosterone does a lot that historically we've pinned on estrogen. And yes, estrogen does those things, but so does testosterone.
Right.
And so if we don't have it or it's getting neglected, she may not feel like her optimized self.
Right. And so when you talk about balance, that reminds me of some of the side effects we see from testosterone, which can be some more masculine features.
Yes.
And how do you navigate that when you're talking to your patients, and how do you keep them out of that kind of risk?
So there's 2 types of ratios I'm looking for. One, testosterone, if it's too much, or if it's going down a particular pathway, we call it the 5-alpha pathway. And it turns into something very, very potent called DHT, dihydrotestosterone. And DHT binds to receptors really strongly. Like it loves the receptors for androgens like testosterone. And if it's too much, then we get hair loss, hair thinning, cystic acne in places we don't want, hair growth in places we don't want, anger, things like that. Some women genetically just don't go down that pathway. Like, not to say that I can't get those side effects, but I don't go down that pathway. Whenever I test, that's not the preferred pathway. Other women, maybe if you have a PCOS diagnosis, polycystic ovary syndrome, you are more likely to go down that pathway. And for other women, it's kind of 50-50. Well, we can test that pathway. And that's what's so nice is that I can see ahead of time, are you likely to go down that pathway or not? Now, the other ratio I look at is testosterone to estradiol, because It's a relative ratio between the two. Yes, we have more testosterone molecules than estrogen molecules, estradiol molecules. But once the gap starts spreading, testosterone's perceived higher than estradiol. Now women look what we call more androgenic, and that can also bring on symptoms and side effects.
Okay.
So it may not be actual high levels. It's just relative to estrogen, we have an issue. So now she's like, I'm gaining weight around the middle. I'm losing hair. I'm getting this acne. What's going on? It's not because her level's too high. Again, it's this ratio.
And what should that ratio be? Is there...
So that's a great question. They're still working on it in the research.
Okay.
We know it exists, testosterone and estradiol, and we know there's some cool research on as the gap widens, her risk for the weight gain around the middle, the visceral adipose weight gain, can happen, but we don't actually have a mathematical ratio to figure it out.
Yet.
But I can tell just visually. So if I'm looking at a report, or any kind of saliva test or a urine test or a blood test, I can kind of get an idea of like where you are in the range versus where your estrogen is in the range of who's winning, so to speak.
That's awesome. And so let's go also to the testing for DHT. What kind of testing do you do? Is that a simple blood test that you just get one slice, or do you do something like the hormone zoomer? Or
so you can do either, but there's real big caveats. So you can get DHT in a blood test, which is not uncommon. Some people will run it, especially if you have those side effects or maybe PCOS. However, it turns out DHT is largely an intracellular hormone, meaning it likes to stay in the cell. Kind of like we're in this room, it likes to be in. It doesn't like to be out in the bloodstream. So what we have found, and it's largely through PCOS research and even prostate research, which I'm aware that's men's health, but we can apply it to a degree for us. What we look at is another marker called 5-alpha androstenediol, which is a total mouthful. I did not name it. But what we've seen is that when 5-alpha androstenediol is elevated in urine testing, that is a great indicator. DHT is probably really high in the cell. It's stuck in the cell. It can't get out, but it is causing a ruckus. And so by having high levels of 5-alpha androstenediol, immediately I'm like, okay, you're going to have side effects. We need to adjust for it.
And I think women should know that because women hate hair loss.
Hate it.
Yes.
They hate all of it. They hate anger. They hate cystic acne. They don't like their upper hair lip or their chin hairs. I don't blame them. They don't want the hair loss. They want to keep their hair.
Right.
And what's frustrating is that they will get a blood test for testosterone and get told it's normal. And it is normal. It's in the range.
Yeah.
And yet they have all these symptoms.
Okay.
If we just look deeper, if we just looked at DHT, if we looked at 5-alpha androstenediol, it could show up there.
Right. So that's why those metabolites are so important.
So important. It's like peeling back the layers of an onion.
So fascinating. I mean, I'm telling you, this is like blowing my mind. You're talking to me. I'm so excited about this conversation. So then what do you do to stop that conversion to DHT? Is there anything you can do, or is it just scaling back the testosterone?
You can do both.
Okay.
So you can scale back the dose of testosterone. Sometimes some very overeager practitioners will start a woman on a higher dose of testosterone. They'll jump in at like 3, 4, 5 milligrams of testosterone. And if you are already a sensitive person, you know, based on your medication history or supplement history, you need to start with a low dose. You probably should start with a low dose of testosterone too. But there are what we call blockers. So there are 5-alpha blockers to help reduce that pathway that we can use to slow it down. If that's the case.
Are these like finasteride or?
That's an option for sure. So we have pharmaceutical blockers. We do have some natural supplemental blockers. The research isn't as strong. We use a lot more anecdotal, meaning what's worked in my patients, what's worked in your patients. So things like reishi mushroom, saw palmetto, stinging nettle root.
Okay.
Often zinc is mixed in there as well.
Okay.
Can very mildly help reduce that as well.
That's why all those hair gummies work in
That's
that way.
why people are putting them in the hair products. Yes.
I love it. I love it. So then when you mentioned some of the foundational things that can help ease some of these perimenopausal symptoms, you mentioned cortisol with that. Talk to me a little bit about cortisol. And then I want to go into some of those foundational lifestyle fundamentals that can help too.
Yeah. In the steroid pathway, what people forget is it happens in the mitochondria. So when it comes to good health and health span, we have to protect our mitochondria. And when we're talking about hormone health, we have to talk about the mitochondria. So what happens is the brain goes down to the ovaries and says, do your thing. But it does so by binding to the mitochondria. You make a hormone called pregnenolone in the mitochondria. It's the very first step for everything. It leaves the mitochondria, goes next door to a little organelle called the endoplasmic reticulum. And then everything else, because it becomes its hormone, progesterone, testosterone, estradiol, except cortisol. Cortisol comes back and finishes out in the mitochondria as cortisol. So mitochondria is extra, extra, extra critical for cortisol production because it starts and finishes out right there in the mito. And if your mitochondria aren't functioning that well, you're probably going to struggle with cortisol production in the first place.
Okay, so then talk to me about cortisol as it relates to stress.
Yes.
And talk to me about what that does to our mitochondria over time.
Oh my gosh. Yes. And we unfortunately live in such a stressful world. And then the act of going through perimenopause, because there's a lot of unknown, there's a lot women can't control for, don't feel they can control for. So it adds extra anxiety and pressure onto them, adds to stress. So stress is what we call sympathetic. It's our fight or flight, freeze type of side of our body, as opposed to parasympathetic, rest, digest, repair and heal, as an example. So we have the sympathetic side, and we need it. It helps us for survival. It helps us for good things. When we exercise, we're planning an event, we're doing a sprint at work, we're doing all the things. But it also, again, if we get a nasty text, if we have to swerve on the highway to avoid an accident, if we read the news and it's stressful, the body is going to respond. Initially, not a problem. When you exercise, I want my body to be like, I got you, we're running, we're fighting, we're lifting, be stressed, and then go back to baseline. What happens is people are chronically stressed. So they're chronically, maybe let's say inappropriately producing cortisol amount or at the wrong time. So as a result, they often suffer with sleep issues. They suffer with weight issues. They suffer with energy issues. They suffer with hormone issues, et cetera, because cortisol is just responding to what's happening, but it's creating all these symptoms in our body. And we forget cortisol is what we call a glucocorticosteroid. Gluco meaning glucose. So cortisol increases glucose in the body, our blood sugar. It's its primary job. It's its first thing on the resume. So if you're chronically stressed and you have chronically elevated cortisol, it's probably going to chronically disrupt your glucose at the same time, and that's no good.
Right, and leads to all kinds of metabolic disarrangement.
Yep.
Also, at the same time, it's stealing from those other pathways. If you're taking pregnenolone and you're shunting it towards cortisol, then you're not making as much of your other androgenic hormones.
And it starts at the brain. So if you are chronically stressed, remember, your brain is constantly surveying what's going on around you. Are you healthy enough, safe enough, good enough? Is everything all right for you to make hormones appropriately? And hormones are made in pulses. It's not like a hose. It's not like we just turn on a hose and out comes hormone. They're pulsed out intermittently. So if the brain feels this is not a good day or this is not a good week or it hasn't been a great month, then it's going to adjust. And so if cortisol is really high, then the pathway to make progesterone, as an example, is not going to be that great. So it's going to adjust resources from the brain down and say, ooh, not today. We're not going to do this today.
Right.
And what do women have? They'll be like, oh my gosh, my period was early. My period was late. My PMS was the worst. My cramps were terrible because the brain took all this information in and said, not this month.
Right.
Yeah.
Yeah. And I always say, you're saying not this month. And I'm going, yeah, that's like what the body says when it's hard to get pregnant, because what's good for health is good for fertility. And I think back to my own journey several years ago where I switched to a very clean diet and I started protecting my sleep. And all of a sudden my symptoms around my cycle were getting a lot more manageable. There was less PMS. There was less pain with uterine contraction, all of those things. So talk to me about that foundational bit, those things that we can do in our lifestyle that help to regulate these signals.
Oh, huge. Because the hormones are like divas. They're the canary in the coal mine. They react and then act accordingly. So if you have your foundations really dialed in, if you protect your sleep, I love that you said that. If you have your nutrition dialed in most of the time, you are working on your stress management, however that looks. You've got a great community and joy. You're moving your body, you're exercising, you're detoxing, you're reading labels and being mindful of endocrine disruptors. Those are the big foundations that the brain can now breathe a sigh of relief. Like, oh, I feel safe. You feel safe. Like, okay, we can make hormones appropriately. But when those things get knocked off kilter, they get forgotten about. You're traveling, you're not eating well, you're not exercising, you're stressed out. and the brain feels the same thing. And as a result, your hormones aren't made appropriately. So while I love hormone therapy, don't get me wrong, absolutely big fan of hormones and hormone like estrogen, progesterone, testosterone, et cetera, you have to interlace in the foundations at the same time. Because estrogen alone as a therapy or replacement or optimization is not going to necessarily bring you joy, or it's not going to get you to lift that weight, or it's not going to get you to like say no and set boundaries and take care of yourself.
Which is why I love what you said in the beginning was like you run the test, you start those lifestyle things, and then you go in and look at the information and the data you have and then approach that maybe through further treatment.
Yes.
Do you a lot of times see people that can affect their hormone balance with lifestyle alone and then they don't need treatment and they're thankful for that? And kind of delay the onset of further symptoms?
It depends on their age.
Okay.
So I have found what we see a lot now in social media is that, women in their 30s, sometimes in their mid to young 30s are saying, oh, it's perimenopause. I have perimenopause. And I would maybe. However, I would argue it's probably other hormonal dysfunction. And I bet if we did a little bit of workup, and we really focused on the foundations or figured out what's going on, it's not perimenopause. It's just hormone dysfunction due to everything else. So in that case, I would say, yes, we can do a lot of lifestyle changes, maybe add some supplements, not necessarily hormone therapy, and you would feel great. Once you do get into perimenopause though, once you're in it, then it definitely, I'm still a fan of foundations. You can't neglect them. But at that point, I'm like, if you want hormones and you're a candidate for hormones, we should talk about hormones.
And what does that look like, the candidate for hormones? Are people getting, I guess my question is, with all of this trend to push towards perimenopausal or hormone replacement therapy, are people now getting treated too early? Or you think that we're right in assuming that some of these fluctuations, maybe in the late 30s, early 40s, really do need some support with bioidentical hormone replacement?
And I think the answer is both. And I think it depends on the person. And this is why I'm so thrilled so many healthcare practitioners are getting educated into hormones or getting certified, because they can have these nuanced conversations now with their patients. They can really assess, is now the time for hormones, or are we talking like, ooh, your life is kind of a hot mess express, or you've been through a lot, maybe we should get that balanced and worked on before we consider hormones. And what is their goal? There are a lot of women that don't want hormones. There are a lot of women aren't ready for it. It makes them nervous, or maybe they're going to like dip their toe in. They'll try a little progesterone. So I'm just there to meet them where they're at and what they feel comfortable with. But I do want to make sure they're educated. I would hate for people to wrongly assume things about hormones. That's sort of that old, misdated Women's Health Initiative information that still circulates.
Right. So the fear is breast cancer.
Always, yeah.
Fear of maybe clotting.
Yep.
Which can be significant, and then there's also kind of that maybe I don't have it. Maybe I'm that kind of misinformation of, no, I'm not supposed to get that till I'm in my mid-50s. Right. And so then they go a long time without hormone replacement therapy. And the flip side of that is maybe worsening bone health or heart health.
We call it, my longevity friends call it sort of like the 4 horsemen or the 4 horsewomen of the apocalypse. So the things we're trying to protect against are cardiometabolic disease, so heart and metabolic health, neurodegenerative disease, so Alzheimer's, dementia, and even just really bad brain fog, diseases of frailty, so osteoporosis, osteopenia, break a hip, and then lastly is cancer. And so when women are waiting, because there are 2 camps around hormone therapy. I don't know if you've noticed this, but there are some experts who feel women shouldn't start hormones until they've stopped their period, gone a full 12 months, no period.
Right.
And then there's others who go, no, once you're symptomatic and you're even like long periods, skipping periods, things are a problem, you need hormones. I'm in that camp. I'm in the camp, like if you want it, need it, let's do it. But once you start skipping periods, you've gone 4 months, 6 months, 8 months, 12 months, no period. Like that's a long time, no hormone.
Right.
And especially if you don't have any foundations under you, you probably don't feel that good. You're probably really pretty symptomatic. Obviously, there are a lot of women who are doing great. They've dialed everything in, their nutrition, their exercise, their stress, their community, et cetera, and they feel amazing. I have women report back to me going, I do all those things. I'm not on hormones yet. And I feel great. I'm like, great. You're not who I'm talking to. It's the other women, right?
Yeah.
That are not having that experience. And that's okay.
Right.
We just support them differently.
I love that. I love that personalized approach. Talk to me about the WHI. How do you explain to people? Because this is a question I get a lot whenever we're trying to start people on hormone replacement therapy. There's a lot of fear, and especially like my mother's generation,
Yes.
a lot of fear over hormone replacement therapy. I just won't do it. I'm so scared of breast cancer. How do you talk to your patients about that, and what kind of misdirection the WHI gave us?
And gosh, the WHI still has so much misdirection. I'm sure you've seen if somebody goes and gets progesterone, right? If they get vaginal estrogen, the black box warning, the full on scare, like this causes cancer, be careful. I'm like, whoa, this is not what this was meant for at all. It just got slapped onto every single hormone out there. Right. So the Women's Health Initiative was a research study that in 2002, they came out and said, stop the presses, hormones cause cancer, particularly estrogen. What's fascinating to me is that the design of the study maybe wasn't that great, and who they chose and what their age was. Some of their interpretations now have come out years later, and they're like, oops, we misinterpreted that a little wrong. And subsequent studies have come out that say the opposite now. Some of the authors have come back and realized like that was wrong.
Right.
And then there were two groups to this study. There was the group that had what was Premarin and Provera. So a synthetic estrogen, which is called a ethinyl estradiol. And then we had Provera, which is a progestin. And then and they were together. And then the second group were women who were just on the synthetic estrogen. And the synthetic estrogen arm didn't have an increase in estrogen or in cancer.
I know.
And they kept it going for years. So they stopped the progestin estrogen combination, but kept the synthetic estrogen going. And what's amazing is that the one that they kept going, when they did the follow-up for that, it still didn't have increased risk of breast cancer. But that's what made the cover story of everything, which was estrogen causes cancer.
And do you ever think they'll try to not the NIH, but do you think that there's enough rallying around hormone replacement therapy to really know what those end results could look like, that study may be repeated?
I would hope so, but it's a lot of money. I also realized I said ethinyl estradiol and something I meant CEE, conjugated equine estrogen, because it was the pregnant mare urine that they used.
Yeah.
But even then, which we still have available, to us, we can still use the conjugated equine estrogen. But in order to repeat that study cost a lot of money. I don't think people realize the amount it cost. And then so to repeat it, I think a lot of input would be had. It would also include progesterone, estradiol, and it would be need to be done a whole lot differently.
Absolutely.
So I would be thrilled if they upgraded and redid that study. But knowing what it would take and the amount they poured into it, unfortunately, I don't think it's going to happen anytime soon.
Okay.
But what we do know is we've had a lot of other studies come out since then, at different scale, smaller scale, much more positive, much less worrisome. And so that's what I try to coach women on, is like, the WHI had a lot of design issues, a lot of interpretation issues. And since that time, we've learned a lot.
Right. And the benefits seem to very much outweigh that minor hesitancy of the risk.
Yes. It's a very tiny risk. And even you mentioned clots as an example. The clots is if you swallow the estrogen, right? And now I would say most women are probably starting on topical, whether it's the patch or a gel or the spray, which doesn't have the increased risk of clots.
Yes.
So I know women who go, I have either genetically, I have clots, or I have a history of clot, or I had a clot when I was pregnant.
Right.
And now it's fast forward, I'm perimenopausal. I don't think I can do estrogen. And even that has been found to be, we have to talk to your practitioner. What's the route of estrogen you're using? What kind of clots are we talking here? It's not an absolute, and it used to be absolute. So we're learning a lot. It's just taking decades to get there.
Right. And that transdermal also helps with lowering those buses, so to speak, that sex hormone binding globulin.
Yes.
And so
For
you have
testosterone.
Right. Have more circulating active hormone.
Yes.
So that, I mean, that's the route I use for all my patients. I have found some patients who come to me later who are on oral, and I try to explain that to them and get them on a transdermal delivery. But again, I agree with the vaginal estrogen. I don't think people understand how important that is for the receptors of the urothelium and the vaginal, the vaginal mucosa and all the receptors that are there, not only for estrogen, but also for DHEA.
Huge.
And how it can affect your overall mortality and UTI risk. And
it's massive. I mean, now the whole paper, Dr. We have two great papers. So one, we have the genital urinary syndrome and menopause. So now the guidelines have come out, and in the American Urologic Association and then the Menopause Society Association, and I believe even ACOG, the American College of Obstetrics and Gynecology, they've all kind of agreed, like genital urinary syndrome, we have to take it seriously, and low-dose vaginal estrogen, estradiol, and DHEA, really pretty safe. And just as you said, prevents a lot of things, reduces the risk for a lot of things. And so that is huge because that still has the warning label on it that hormones cause cancer and you have to be really careful. And so women are avoiding that when now we have the research to show that we don't need that warning on there. And they're trying to change that. The other really cool paper, which is not genital related, but musculoskeletal, as Dr. Vonda writes, musculoskeletal syndrome of menopause, because it's taken us decades, but we're realizing the breadth and depth of how much these hormones impact the body. So joint pain, muscle pain, again, osteoporosis, osteopenia, fibromyalgia, like all these things women are getting told they have, not linking
related.
it to hormones.
I just realized in recent months that there's also receptors in the inner ear canal. So, right? And then this morning I was talking to a friend, she had some eye changes. Her doctor was telling her around 40, the cornea isn't as flexible. And then I was like, I just need to look up. Is there estrogen receptors in the cornea? And there are. And so all of these changes can be related to a lack of estrogen.
I went to my eye doctor. I was probably 44 when I went to my eye doctor. And I was like, I wear contacts or glasses. And I said, I'm noticing, I think I have the wrong prescription because my contacts, I can see distance, but not quite as up close as I used to. And so she did the whole exam, and my sweet eye doctor, she goes, you just have eyes in your 40s now. They can't snap back like they used to. You can't go from distance to up close really quickly like you could in your younger years. Right. Welcome to your 40s. And I was like, what?
It can't just be the answer.
What? And and now I'm 48, and every time I go to the eye doctor, I'm like, are they still in their 40s? Have they changed at all?
Have they changed at all? Are they any better?
What are they like?
Do the hormones help them?
Yeah. Well, I'm not on estrogen yet. I'm not there yet. But I'll be curious. I have not changed since 44. I am the same prescription, the same sort of everything.
Okay.
But I do get itchy ears.
Okay.
Because lack of estrogen can dry things out. So dry joint, dry skin, dry vagina, dry itchy ears.
Wow.
And I have had phantom smells, which because you have estrogen receptors on the nerve that impacts smell.
Okay.
And so you can there's some thought around this phantom smell. Other women are like, no, I think the shift in estrogen just makes you hyper aware.
Okay.
And so I haven't quite dug into that research yet but some people get cigarette smell. I get sewer smell, which is lovely. Other people smell electrical wire burning, and it comes and goes. It's random and nobody else can smell it, which is why we call it phantom smells.
I love it.
So these random little, things you would never think can be related.
That's wild. Yeah. And the reason I brought up the inner ear is a lot of people will suffer from
vertigo and tinnitus.
Vertigo. That's what I was trying to come up with. Thank you. Yes, vertigo.
Yeah.
And can really be not maybe totally relieved, but helped with estrogen replacement.
Yeah.
And there was also that, you can only be on it for 10 years and then you have to come off of it. What do you think about that?
My gosh. And that was the big thing. So when I was a second year medical student when the WHI came out, and my attending, thank goodness, was like, I don't think so, because they're not stopping the birth control pill. but they think this is causing cancer. Like, are we sure about this? I think this is going to do more harm than good.
How insightful.
I mean, learned
just amazing.
Huge. So I learned to prescribe and continue to prescribe, but it was smallest dose for the shortest amount of time. That was what was portrayed out there.
Okay.
Now, I believe it was 2024 that has made the headlines and news is that if you're on it, as long as you check in with your practitioner and, you get worked up, you can stay on it until you die if you want to.
Definitely.
And you will see a lot of people out there, a lot of practitioners out there who were like, you know what, I'm going to die with this in my hand. I'm not going to let go of it.
Right.
Because once you stop, you can lose the benefits.
Yeah, absolutely. It goes right back to your regular bone fracture risk.
Right, which we're trying to avoid. Between bone, brain, and potentially heart, cardiometabolic, we've got to be careful. It's not a prevention at all, of course. It's not a first-line prevention for it, like heart disease is an example.
Right.
But if we can continue to keep healthy capillaries, healthy arteries, nitric oxide levels, like all the heart healthy things, starting, let's say, in your 40s and you maintain it, it may definitely reduce in the future. Like, we're still looking at that.
Right. And I love what your attending did. Another lesson probably subconsciously was kind of question everything. Don't take everything at face value and kind of make your own, rational, educated decision for your patients and for, anything that comes. And I think that that's hugely valuable probably for you over time.
Yeah.
And when we talk about, so we've looked at, okay, patient comes in, they've got their symptoms. You start them on foundational changes. You look at their lab work. You decide on a treatment plan, perhaps. Is there anything else supplemental that can really help the majority of patients who are going through these perimenopausal hormone changes that maybe we don't know about or that you kind of prescribe for most people or suggest?
Yeah, so a lot of it is things like electrolytes and minerals. I find a lot of people are either underhydrated or they drink a lot of water, but it's just plain water and they're just peeing it all the way out. They're not even absorbing it. So electrolytes and minerals are huge. A lot of people I think are magnesium deficient, and magnesium can be really helpful.
Okay.
I find there was a study that I saw yesterday or the day before about fish oil, EPA and DHA. It's linked to Alzheimer's, especially in women. Like, we struggle to get the DHA and EPA up into our brain and use it effectively. And so getting healthy levels of omegas either in our diet, that's can be hard to do, but getting, even supplementing with a good quality omega oil could be really, really helpful. You will see now a lot about creatine. And creatine we used to think was like, oh, that's what the bodybuilders use. We don't use this. But it turns out creatine is really helpful for, a lot in the body, but muscles, potentially for brain. It could potentially be helpful for detoxification in a roundabout way, which is very cool. And so now I'm loving the research out there of like, creatine's for everyone, not just, sort of the bros that are bodybuilding. And then from there, it's definitely individualized. Do you need more vitamin D? Do you need iron? Do you need B vitamins? How's your stress response? I am a naturopathic doctor. I play in the world of herbs. And so what are we looking at when it comes to sleep support? Again, with or without hormones, some people are still need extra support. So what about your stress response? There's a lot of herbs that do a lot of really cool things.
What's your favorite
layer
one?
them in. My favorite herb?
Yeah.
My personal favorite herb for me is called holy basil, which is Tulsi.
Okay.
Because holy basil, it's an Ayurvedic herb and it's calming. It reduces histamine. It's a really lovely tea. It's just sort of an all around, like when you're feeling kind of stressed, it's gentle. I like the name holy basil. So that is a favorite one, a favorite herb for me.
Okay. What is one thing that you could tell women that you think that most women don't know about their general health or hormone health that you would a message you'd like to give them?
Actually, it's not my message. I steal it from Glinda the Good Witch from Wizard of Oz. When she says, you had the power all along, my dear, I find that really helpful because for a lot of women, they don't understand what's happening in this whole transition. They're really rightfully so scared, confused, and overwhelmed. But because it's your health and there's so much you can do. It's just, you need to get the education, listen to podcasts like this.
Yes.
Right? Get testing, be an advocate for yourself, and know that there is a lot you can take the reins and you can take control of.
I love that. Okay, when you're looking at labs, what markers are you really looking for to guide your treatment of your patients?
Definitely a lot of the markers that we've discussed already, let's call those sort of the basics.
Okay.
Then we get sort of the next layer up, which we talked about metabolites. So like the DHT or 5-alpha androstenediol, the estrogen metabolism, where the estrogen's going. And then I get into some of the really cool advanced, like I want to see bone markers. I want to see what is your bone turnover doing. And I'd like to know that early so I have something to compare it to as you move through this transition. I would like to know what your oxidative stress marker is doing. A lot of people don't understand oxidative stress, and I get that. But basically, when women are going through this whole transition and when you're making hormones, when you're exposed to toxicants, which we'll talk about in a second, your body puts off like what we call free radicals, reactive oxygen species. And we have to clean them up, mop them up, neutralize them, and get them out of the body. But if it's overwhelming, then we have a problem. And it can create a lot of symptoms, a lot of mitochondrial damage. So what is your oxidative stress? I want to see that marker, and I'd like to see it early if I can in your transition, and then follow you through. And then I mentioned toxicants. So the endocrine disruptors would be amazing. If I can say to you, look at these plastic levels, your paraben levels, your BPA levels, and it can help maybe motivate to make some changes in your life or how you run your house or the makeup you use or skincare or personal care, or plastic, etc. Knowing that they are literally endocrine disruptors. This whole system we're talking about is the endocrine system. So let's not disrupt it.
Yes.
And by looking at that more advanced, like you've mentioned it already, but something like the hormone zoomer could be really helpful just to get that extra layer and really help women through this.
Wonderful. And that's how you would say, let's say there's a practitioner out there who wants to incorporate those tests into their practice. You think that that's the best way to do it? Are there other ways? Can you cherry pick these tests through other labs, or how would you approach that?
The cherry picking becomes hard. In the blood work, you can cherry pick much easier. Everyone's familiar in how to do that. But to do the other advanced tests, much easier just to do one and done.
Right.
Because it's one collection, one test, one company. It's easier.
What do you find when you do these endocrine disruptor tests? What's usually the biggest culprit for your patients, and how do they get rid of it?
Oh my gosh, I worry a lot. My biggest worry are the forever chemicals, but what I see are the plastics. Yes.
Okay.
Because the forever chemicals, I'm sure you've seen now the articles about it in like our yoga pants, right? And our sports bras and like the things that women are wearing. Like, I'm glad when they're exercising, but then we live all day in it and we're getting exposed and, delicate parts to these forever chemicals. Think of the nonstick pans, think of, the repellent on our couches and our fireproof stuff. I mean, that could be a problem, but the plastic use, we can't get away from the plastic use, but if we can minimize it, that would be ideal.
Do you think sauna helps with that? Or
yes.
Are there any binders that we can take that help with that?
That's what they're really trying to look in the literature right now. So it looks like some heavy use of polyphenols in supplements. Polyphenols are like the things that give foods color. Blueberries, for example, right? The antioxidants. So I'm seeing like some of the polyphenols might be helpful. I don't think you can eat enough blueberries necessarily to do it, but I am starting to look at that research. And I have seen some other very, let's say like more anecdotal or theoretical research around broccoli sprouts. So when you chew or chop broccoli sprouts, the active ingredient becomes sulforaphane. Sulforaphane is a big detox mover for a lot of people. So I'm looking at that. And then I'm looking at another antioxidant, glutathione, which is another big one between that and melatonin. So I'm starting to watch the research on besides sauna, like what else can we eat? What else can be supportive from a food nutrient to help get it out?
Incredible. There's so much to know. There's so much more coming down about hormone health. Where do you think this is going, and what's exciting you most?
Oh my gosh, the pendulum is completely swinging from we don't believe in hormones, it causes cancer, there's nothing you can do, best of luck, here's an SSRI, here's an antidepressant, all the way to the other end, which is we're going to empower the heck out of you. Let's get you on hormones. Let's teach you about the foundations. Let's pour millions of dollars into research to help women understand women better. And I'm so excited for that.
Yes. Okay, good. Well, I think that's a great place to stop today. Thank you so much for taking the time. Everyone can find you on your website, drcarriejones.com.
Yes.
You have classes there. There's links to all of your things. You can go to your YouTube. You're big on social media, especially Instagram at Carrie Jones, and on TikTok.
Yeah, well, I'm getting there.
Okay.
That's the Wild West.
Tell us where you'd like people to find you.
Definitely the website, drcarriejones.com is the landing page because I have everything there, including free ebooks that people are welcome to sign up for and get all sorts of help moving through this like a labs check ebook that could be helpful.
Wonderful. Okay. Thank you so much. You guys go follow Dr. Carrie Jones. She is a plethora of knowledge, and we are so fortunate that we got to have you today on the podcast. Thank you all for listening. And if you would like to hear more, please subscribe to the podcast. If you want to see what we're up to next, please follow us at Vibrant Labs, and we'll see you next time.